So total arthroplasty is basically a procedure of 150 years history. And posterior approach was first described in 1874 and later it was performed in 91. So there are these four main approaches. So how many of us doing this arthroplasty through all four approaches? So I've been lucky to see all the four approaches in a different way. I've been lucky to put implant in through these four approaches because of some tumor surgeries. And I have seen all four approaches were different surgeons and different way as well. So I will describe one by one. So this is, if you remember, this is the basic slide. It's a very basic, just to remember the incisions. This is the historical. So for resident, this is very key. This was the beginning incision. People who started the entry approach, they started with the beginning incision. But problem with this was a transverse and somehow very difficult to get the X square without special instruments. So this was somehow people are still not working in, but the people turn this incision to this one. Rightly straight away, right entry approach directly through going to this hip joint. I will show the steps as well. Then this anterior lateral Watson Johnson, this was one of the famous approaches. Still people are preferring to do it because of this internervous plane and there are no muscular muscle cut is involved in anterior lateral. Direct lateral approach is a bit easier. As I was always saying, if you want to do through it, it's very easy. It's no doubt it's very easy, but with hand, it's very important to care of important structure with this direct approach. And the posterior, when we were trained, we all trained with this posterior. So this is basically the basic. So I will start with the posterior first, or the posterior lateral. So for resident, if you sample, there's one station nowadays in the e-log book. So everybody asking you the approach. So there are some certain steps to follow. If you follow these steps one by one, it will hardly take you 30 seconds to describe all the approach. If you don't remember the basic principles, you will have somehow problem in describing the approach. So whenever you ask, describe the approach, remember the few words first. First, what you will do? You keep the patient in a position. Which position you will put in a posterior lateral approach? The position will be lateral. The incision will be right 5 centimeter above the greater trochanter there is curved and 5 centimeter below. So what first thing you will do? One position. Number two is incision. Okay. Then what you will do? Look at this first. Identify what first layer you will find or which structures. So skin subcutaneous tissue, then fasciolata. And half of the gluteus maximus is attached on the fasciolata. Just straight away go, open this fasciolata, split the gluteus maximus, and then what you will find in the second layer, you will interrotate the leg, flex the knee, and you will find out these short rotators. Identify the shading nerve here, and look at this four external rotators. This is superior gemellus, this is obtuse internal, this is inferior gemella, this is obtuse internal, this is quadratus. So see, remember this, and above here you will piriformis. So in arthroplasty you don't go up to look for the piriformis. So this is easy, and in the end you will find out the capsule. So see, it's very easy. It will hardly take you 30 seconds to memorize all. But if you don't follow these steps, remember the where the incision, what will be the position, what will be the layer first, what will you say layer 2, what will be layer 3. Okay? It will be very difficult to remember. But if you follow these 3 steps, all approaches will be a bit easier to find out. Then you will cut the neck and you will go through the neck. So this is posterior and posterior lateral. When you will train, everybody in the JPMC was doing posterior approach. So we, being a resident, all approaches see the posterior. So what is the advantage? We don't touch the abductor. This is the biggest advantage. That's why the people have less lurch. Okay, low fracture risk because of excellent exposure around this and excellent exposure of the acetabular femur. But so this is, and what are the complications to this? Sciatic nerve and inferior gluteal nerve injury, medial circumfemoral artery injury when you cut this quadratus, so somehow bleeding the lower part of the incision, and high dislocation rate was there with this posterior approach. Because most of the time people don't repair the capsule, most of the time they don't repair all the external rotator. That's why there's a higher dislocation rate. But now in NHS, everybody is from anterior to this, they are turning into this approach again. Because they feel there's excellent exposure and the accurate placement of implant is more better with the posterior approach than other approaches. So now everybody in Europe turned to the thing that the entry approach is the best, but this again is the key. When you need entry approach, you need special instruments. It's not that you will put a same home in and you will do this total hip replacement through the entry approach. The key is you must have all equipments available in the table that help you to do entry approach. So I was lucky to see all when I come back to the civil hospital. Afridi sir was doing entry approach for hemiarthroplasty. So first I assisted with him. He was doing hemiarthroplasty through entry approach. And I've seen greater trochanter fractures multiple times and he was putting this omen behind it and there was a fracture. And then this again people are doing in two ways. Either in simple table, they do in a traction table. In St. George Hospital, France, I have seen both ways. One surgeon was doing without traction table, one was doing on the traction table in the entry approach. So this was the table when they were doing with the traction. So what they did, this was applying the traction first. Open this plane. I will show you the which plane they open it. And once they apply the traction, make an osteotomy and remove this head. And once they want to get femoral, so they bring this table down here. This whole then leg comes in this way direction of 45 degree, and put both the humans at just behind the greater trochanter, lift it, and then with a special instrument around they ream the femur. So they do, and it hardly took 40 minutes to do total hip replacement of the section because no person is required. Only surgeon was there, only one assistant, two people are operating, and they operate within 40-45 minutes on cemented total hip. So this is how they modified. So what is the landmark? Again, same. Incision landmark will be 5 cm above the greater trochanter, 5 cm below. Okay, sometimes you can extend 8 cm onward when you do the reviews. So first layer, what will be the first layer? Again, skin subcutaneous tissue, and you will need to find out lateral foot nerve, thigh anteriorly, okay, and open this fascia. What is the beauty in this plan? After opening this, identifying the lateral foot nerve, thigh, you will need to identify sartorius and tensor fascia lata. So you will find out two muscles, sartorius and tensor fascia lata, and nothing to cut. Just make a plane in between both and find out the second layer. And if you see femoral nerve supplying the sartorius and tensor fascia lata is supplied by superior gluteal nerve. So it's a pure internervous plane approach, and you don't damage both of the nerves as well. And if you go down, you need to find out two other muscles, rectus femoris, gluteus medius. So what is the difference? Again, rectus femoris is supplied by femoral nerve and gluteus medius is supplied by same superior gluteal nerve. So again, same nerves supplying both the layers in the approach. And these are some vessels. Sometimes when you open this, around the capsule you get some bleeding. And these are direct branches coming from the femur. So you sometimes people, I have seen the ligating these, or they sometimes cauterize as well. So reflect both, and then in the end you will find out the capsule. So first layer, second layer, capsule. But key is basically patient lying supine. If you don't have special instruments, you always have a problem in getting the square. So you need special hormones to keep this femur in position where you can get the exact orientation of the establishment of the femur as well. And this again is the key. When you apply the traction, do the external rotation. Then you will be able to dislocate the abductor. So what are the advantages? The low dislocation rate, no abductors involved, no muscle cut any plane on the whole of the plane. And this is all pure internervous intramuscular. When you close it, you have nothing to do it. Remove all the instruments, just apply the fascia lata and skin clear. Not a single stitch on all these muscles. And what are the disadvantages? Lateral foot nerve, femur nerve gets injured, so later on might have some meralgia parastatica, might have patient have numbness all around the lateral side of thigh. Femur nerve sometimes have excessive traction because of small space, more chances of pre-operative. Even I have seen people in operating an entry having dislocation in anterior approach as well, through entry approach and per operator. Then they have to change the plane. And fracture around the greater trochanter is more common as compared to other fractures. And in the traction table, in osteoporosis, they apply forceful traction, they have a fracture in the ankle as well. So when you apply the traction, be careful to apply the traction in this entry approach. And the direct, so this is the second one. So this is the third one, the direct lateral approach. Is again, either people are doing in supine or lateral, It depends upon surgeon preference. I have seen Marathis are always operating adding in the supine approach. I have seen Chaisa operating a lateral approach. So we do a lateral approach. Okay, so incision, remember the first thing, position will be supine or lateral depending upon surgeon preference. The incision is 4 cm above, 5 cm down the grunt trochanter. After incision, if you see what is the first layer, skin, subcutaneous tissue, and same facial layer to the maximus. Once you've done the first layer, open on the second. So see this, there are many modifications to this hardening as well. But remember the basic. Cut this abductors with the vascular lateralis anterior 1/3. Leave 2/3 on the greater trochanter. And once you open it, definitely you will open up the capsule and external the limb if get dislocated. So this is, but problem with this is 5 cm above is the superior gluteal nerve. So you have to look about the superior gluteal nerve, otherwise abductor will be having a problem. Okay. So same, if you're doing in supine, you need to flex in 90 degree and external rotate. Then you will be able to dislocate the hip joint. So again, advantages is greater visualization of acetabulum and femur and less chances of dislocation as compared to the posterior. But unique complications is abductor mechanism get disturbed. So most of the patients, not always, but some people have tendon gait. Superior gluteal nerve injury is more common as compared because it's lying 5 cm around the ground trochanter. Femoral nerve is less likely to be injured, but it's a well-known commonly, but there is risk of heterotrophic ossification. So the last one is anterior lateral approach is the Watson-Jones. I've seen the people are still operating with this Watson-Jones because they feel it's still an intramuscular plane, so no muscle is disturbed. So look at this position, supine, but always need to put a pillow around the buttocks to lift it around at least 20-30 degrees. So that makes it easier to look into the acetabulum and the femur. Incision around the greater trochanter 5 degrees, but it sees it, it's redirected towards the anterior and field spine. And inside, if you see the same, first layer is the same skin, subcutaneous tissue, facial lata, and the gluteus maximus. Split it. But here you have in second layer, you need to make a plane between the gluteus medius and tensor facial lata. And once you make a plane in between, then you will need to find out, sometimes you need to cut out this vascular lateral as well in this approach because it won't allow you to go to easily approach this capsule. So it's some tricky, but it's still a valid option for approaching the hip joint. So good neck exposure, low dislocation rate. That is still where people are doing it, Watson-Jones. So disadvantages again depend upon version, femoral nerve injury, and abductor mechanism somehow you're going to disrupt. So if you want to add an exposure to all these approaches, you're gonna have 3 types of osteotomies around the hip joint. A is, if you see this, all gluteus medius minimum attached here. So if you want to make osteotomy through the greater trochanter, both attachments go with this trochanter. So this is basically trochanteric, this is standard trochanteric osteotomy. Number 2, if you go and involving this both abductors and extending up to this origin of this vastus lateralis, so still this is called trochanteric slide osteotomy. And the third one is when you took this all and 2/3 of this proximal lateral, 1/3 of this femur, only lateral cortex. So this is ETO, extended trochanter osteotomy. So all 3 approaches, when you need extended exposure and revision, so you can do exposure through these 3 trochanteric osteotomies. So my conclusion is surgeon should be familiar with all approaches. I being a tumor surgeon, I always think there must be no restriction through all approaches. You need to learn all approaches because sometimes people do biopsy from wrong side. You need to go on a middle side. You got a huge mass on middle side. You got a posterior. You got an anterior. So I always think that all approaches you should be familiar. And definitely surgeon should be familiar as a single approach, and you want to do it, do in a best way. But to me, I always think you must be familiar with all the approaches. And access the hip, the way surgeon feel the comfort is the key to get the result in all the types of total hip arthroplasty. Thank you very much.